Good morning. Hi.
Good morning. Good morning.
We should start, Dr. Ajay.
Mr. Sushil? It's live.
YouTube is live. YouTube is live.
Yeah. So, good morning, dear delegates. We welcome you once again for the session. Today it will be aplastic anemia by Dr. Puneet Sahi. She did her graduation from MAMC and did her residency in AIMS. And then she was a senior research associate at AIMS. Now she is associate professor of pediatrics at Maulana Azad Medical College, Delhi. And she is also the deputy editor of IPK Journal. And she has more than 100 publications to her name. And before she starts sharing her screen, I invite all of you for the physical contact program on 3rd of September. It will be held at Chacha Nehru Bal Chikitsalayah in East Delhi from 9 to 2 p.m. 9 a.m. to 2 p.m. I'll share the details today or tomorrow. Thank you so much. I request Dr. Puneet to please start her presentation. Thank you.
Thank you so much, Dr. Ajay and Dr. Vipul. Thank you to all the organizers for giving me this opportunity to be a part of this wonderful teaching learning session, and congratulations to all the speakers who've given excellent talks till date. So quickly moving on to the topic of today, that is aplastic anemia, which is also the barren bone marrow. So you see, bone marrow is an important organ in our body, which is capable of producing all the blood cells. So usually the bone marrow looks like the picture on the left, which is producing full of blood cells, precursors, and their subsequent mature forms. However, in aplastic anemia, this bone marrow becomes barren, just like what you can see behind my photograph. That's a barren land, and it fails to produce any blood cells or severely deficient blood cells. So that is what aplastic anemia is, where bone marrow goes hoary and barren. So the history started way back when the description of aplastic anemia as an empty bone marrow in which the hematopoietic cells have been replaced by fat cells was first made by Dr. Paul Ehrlich. This is a picture of Dr. Paul Ehrlich. He was a renowned German physician and a Nobel laureate who was known to have come up with a cure for syphilis. And then ultimately he developed a lot of antimicrobial chemotherapy. So what is the definition of aplastic anemia? Aplastic anemia is characterized by 1, the failure of the bone marrow to produce blood cells. Now this leads to decreased numbers or cytopenias of at least 2 of the 3 main cell lines, that is RBCs, white cells, and platelets. However, both these criteria make a diagnosis of aplastic anemia only in the absence of bone marrow infiltration by malignant cells, in which case you will label the child as a malignancy only, or myelofibrosis. So there shouldn't be myelofibrosis or bone marrow infiltration in the child. So bone marrow failure with decreased peripheral blood counts. Now, by how much should these counts be decreased? Before we categorize that, we need to know the normal. So the normal bone marrow cellularity in infants is around 80 to 90%. The remainder is fat cells. As the age increases, the bone marrow cellularity decreases and the proportion of fat cell increases. So at 2 to 5 years, 60 to 80% of the bone marrow is composed of cells, and at 6 to 12 years, around 50 to 70% cellularity is present. RBC count we all know. Reticulocyte count, the usual is 0.5 to 2.5% of the RBC count. So we forget this part of the RBC count. So actually, the absolute reticulocyte count should fall somewhere between 50,000 to 1.5 lakhs per cubic millimeter. The absolute neutrophil count is 1,500 to 8,500, and platelet count we all know. So how do we classify aplastic anemia? In fact, severity of aplastic anemia was given more than 40 years ago by the Gamitas criteria. Now, don't get too worried by too many facts on this slide. Just focus on the 4 parameters on the left. 1, the bone marrow cellularity. Second, the reticulocyte count, which is a marker of decreased erythroblastic lineage, the absolute neutrophil count, and fourth is the platelet count. So in all forms of aplastic anemia, the bone marrow cellularity is reduced. It has to be present. And along with that, 2 of the 3 criteria of peripheral blood cytopenia should be met. So focus on this severe aplastic anemia. In severe aplastic anemia, bone marrow cellularity is less than 25%. The reticulocyte count, which normally is 50,000 to 1.5 lakh, is less than 20,000 per cubic millimeter. The absolute neutrophil count is less than 500 per cubic millimeter, and the platelet count is less than 20,000 per cubic millimeter. So if you remember this severe aplastic anemia criteria, you will know very severe aplastic anemia is just the same, except that ANC is less than 200 per cubic millimeter. And mild to moderate aplastic anemia is reduced bone marrow cellularity and reduction in 2 of these 3 cell lines, but not meeting criteria for severe or very severe aplastic anemia. So what is the epidemiology? It's a rare disease. So 2 to 2.3 cases per million population per year is what is reported worldwide, while in Asia 7.4 cases per million per year of population. There is no gender predilection, so males and females are equally afflicted, and the median age at diagnosis is around 8 to 9 years in children and adolescents. So what is the pathogenesis of this disease, aplastic anemia? So you know that within the long bones of the body is the bone marrow where the hematopoietic stem cells are there. Now there can be certain acquired insults, which is also known as the acquired aplastic anemia, which is responsible for 70 to 80% of all cases of aplastic anemia. So whenever there is a certain infection, viral infection, or there is a use of certain drugs, the use of radiotherapy or chemotherapy, an insult occurs to the hematopoietic stem cell and they become genetically altered. Or in 20 to 30% of the cases, there is congenital or inherited aplastic anemia, which is 20 to 30% of the cases. In them, there is a genetic defect which leads to genetically altered stem cells. Now, because of these genetically altered stem cells, what happens? There is expression of new abnormal antigens. So these antigens are now new. So what happens is that the T cells get activated and the autoimmunity gets activated. So T cell cytotoxicity and the associated interleukins interferon gamma, which plays a central role in the pathogenesis of aplastic anemia, happens, and they start to develop autoimmunity. So like autoimmune thyroiditis means that all the cells of the thyroid gland get killed. Autoimmune in aplastic anemia, acquired forms especially, autoimmunity is directed towards the hematopoietic stem cells in the bone marrow. So the bone marrow gets damaged and ultimately there is pancytopenia. Likewise, in congenital or inherited bone marrow failure syndromes, the more important pathogenesis is abnormality in the cells. So, for example, in Fanconi's anemia, DNA repair mechanisms are defective. So what happens is these cells have decreased survival and proliferative capacity. So the hematopoietic stem cells, they proliferate less, they differentiate less, and they have more apoptosis. So ultimately stem cell damage occurs, and we know that stem cells are the ones which ultimately produce red blood cells, white blood cells, and platelets, and all of these get reduced. So bone marrow failure occurs and peripheral pancytopenia ensues. So etiology-wise, as I explained in the previous slide, acquired aplastic anemia is responsible for 70 to 80% cases of aplastic anemia. And in 70% cases of acquired aplastic anemia, we are unable to identify an underlying cause, so they are labeled as idiopathic. The remainder 30% cases of aplastic anemia are contributed by inherited bone marrow failure syndromes or inherited or congenital aplastic anemia. These are inherited bone marrow failure syndromes. For example, Fanconi's anemia. You should know about Fanconi's anemia. Now, why is this distinction important? It is extremely important because the treatment is different and the prognosis and follow-up is completely different in these two cases. So you have to differentiate. All aplastic anemias cannot be treated alike with immunosuppressive therapy. The distinction is crucial. So further going into the delineation of what could be the causes of acquired aplastic anemia. So 70% of the cases are idiopathic, but they can be secondary to treatment-related factors. For example, radiotherapy. Even 5 grays of radiotherapy can lead to bone marrow aplasia. Then drugs, chemotherapy. Many of you must have been using chemotherapy in the wards, and you know that they go into cytopenias approximately 2 to 3 weeks into the chemotherapy. Then there are certain antibiotics. Surprisingly, cotrimoxazole, which is used as a common prophylactic agent in many kids with aplastic anemia as well as with leukemias, can result in cytopenia. Now, drug-related cytopenias, aplastic anemia, can be of 2 types. One is dose-dependent and reversible. So radiotherapy and chemotherapy results in dose-dependent and reversible aplastic anemia. You know that once you withdraw the chemotherapy after a certain point in time, the bone marrow cells are going to recover. But there are certain other types of reactions known as idiosyncratic reactions. For example, what happens with ceftriaxone or cotrimoxazole? Here this is not dose dependent. It can happen at any dose of the antibiotic, and it is usually irreversible. So that is the more dangerous of the acquired aplastic anemia due to drugs. Then there can be certain chemicals and toxins. Then there will be certain infections, which I'll discuss in the subsequent slides. But remember that it is mostly the viral infections that lead to aplastic anemia. Bacterial parasitic infections leading to aplastic anemias are known, but not very common as compared to the viral infections. Then malnutrition, specifically kwashiorkor, can result in aplastic anemias. Vitamin B12 and folate deficiency we cannot emphasize enough, because it is an important cause, especially in our country, because if aplastic anemia is due to B12 folate deficiency, you know what the treatment is. It is just a supplementation, whereas if it is an aplastic anemia secondary to other causes, you know that you might need to go ahead with a bone marrow transplant or immunosuppressive therapy. There are certain autoimmune diseases like SLE, which is the most important. So ANA is actually recommended to be done in all cases presenting with aplastic anemia. Certain immunodeficiency diseases like common variable immunodeficiency. Then there are 3 categories: hypoplastic pre-leukemia, hypoplastic myelodysplastic syndromes, and PNH. You may not be very well versed with these terminologies, MDS and PNH, but always remember this is a very important overlap with aplastic anemia. They have similar bone marrow findings, but it is important to differentiate these 3 because the treatment was going to differ. Now, can somebody guess who this is? Anybody can respond in the chat session. Who is this? Anybody? Okay, Jasmine, please tell me. Please type it. Yes, excellent, Marie Curie. So that is Dr. Marie Curie. And why I have put this picture is, she was Madame Marie Curie, a Polish physician, a Nobel laureate who conducted research on radioactivity. Ultimately, she passed away in 1934 because at that point, the side effects of prolonged exposure to radioactive substances was not known, and it was from aplastic anemia that she ultimately succumbed. But hats off to this lady. So radiotherapy is one of the causes. So stay awake, guys. There's a lot of etiology and other slides coming up. So what are the viral infections that lead to aplastic anemia? I told you there are several infections that lead to aplastic anemia, but you should be aware of viral infections mostly. So herpes virus like EBV and CMV. Now CMV is an important cause in the neonatal age group to cause aplastic anemia. Then these viruses, hepatitis viruses A, B, C, and non-A, non-B, non-C, non-G hepatitis, which is also known as the seronegative hepatitis. These hepatitis viruses are responsible for almost 5 to 10% cases of acquired aplastic anemia. Very important, and amongst them, actually the seronegative ones are the most commonly found. Then you have HIV. Parvovirus B19 is conventionally associated with pure red cell aplasia. However, it can lead to aplastic anemia. Other viral infections like MMR, influenza, parainfluenza, dengue, varicella, they are usually associated with transient cytopenias. So cytopenias due to viral infections are transient in almost 80% cases. You just follow them up and they'll recover spontaneously. However, the group that you should be scared of is these hepatitis viruses, because hepatitis virus related aplastic anemia is more severe and less likely to resolve spontaneously. Hepatitis associated aplastic anemia usually develops around 2 to 3 months post an episode of acute hepatitis. It is often seronegative, so this group, and accounts for almost 5 to 10% cases of all aplastic anemias. These are the ones who usually need a bone marrow transplant, and if matched sibling bone marrow transplant, and if not available, at least immunosuppressive therapy, because they do not recover spontaneously. Now, the second group of causes are the inherited aplastic anemias. I've given you a list of 5, but this is a partial listing. There are many more examples. So first, let me tell you what exactly are inherited aplastic anemias or inherited bone marrow failure syndromes, IBMFS. They are characterized by an increased risk of developing aplastic anemia. So this inherited aplastic anemias, of course, they are at increased risk of developing aplastic anemias. But the second thing is they have an increased predisposition to cancer. Third, they have characteristic physical anomalies. But what you need to remember is absence of anomalies does not rule out an inherited bone marrow failure syndrome. For example, Fanconi's anemia, which is the commonest inherited bone marrow failure syndromes, in almost 30 to 40% will not have any characteristic anomalies. So despite a person not having any physical anomalies, if he first presents with aplastic anemia, you have to rule out Fanconi's anemia before going ahead with further treatment. Secondly, even though they are inherited bone marrow failure syndromes and almost 75% of the cases present in childhood and early childhood, first presentation can still be in adulthood in almost 25% of the cases. So late presentation also does not rule out IBMFS. Examples include Fanconi's anemia. I'll be giving you some clues later. Dyskeratosis congenita, Schwartzman-Diamond syndrome, which primarily presents initially as neutropenia and gradually progresses to aplastic anemia. Congenital amegakaryocytic thrombocytopenia, which primarily presents as thrombocytopenia but may progress to aplastic anemia and pancytopenias. And Diamond-Blackfan anemia, which primarily presents as anemia and red cell aplasia, but eventually may progress to pancytopenia and aplastic anemias. So now what will be the clinical features? See, the clinical features are because of the pancytopenia. So when the leukocytes are reduced, you know what will happen. There will be fever, there will be recurrent infections, and there will be atypical infections. For example, this child, what does this child have? Anybody? Very easy. What does this picture show in the chats? Yeah, anybody? Come on, guys, this is pretty simple. What is this? All right, so in the best interest of the time, nobody's answering. All right, so this is oral candidiasis. And what's here on the right? These are the typical petechial rash which happen due to thrombocytopenia. So decreased leukocyte count results in fever, recurrent infections, and atypical infections. Reduction in hemoglobin. What will it lead to? All complications associated with anemia. So there will be pallor, there will be fatigue, there will be loss of appetite. And what does reduction in platelet count lead to? Skin and mucosal bleeding. So the first manifestations and the common manifestations of decreased platelet counts are skin and mucosal bleedings in the form of petechial rash, purpural rash, and ultimately it may lead to oral bleeds, or it can lead to epistaxis, it can lead to menorrhagia, it can lead to genitourinary bleeds. In many such children, you may find history of recurrent blood transfusions. Now, the second set of clinical features actually which are not present are hepatomegaly, splenomegaly, and lymphadenopathy. So aplastic anemia is different from other causes of pancytopenia in that organomegaly, hepatomegaly, splenomegaly, and lymphadenopathy are not features. So if they are present, you should think of an alternate etiology of pancytopenia like leukemia. So what is present is important, and what is not present is equally important in the diagnosis of aplastic anemia. Now, the next set of clinical features are clues related to etiology. The etiologies of acquired aplastic anemia that we discussed, and etiologies of inherited bone marrow, inherited aplastic anemias that we discussed. So, if there is history of radiation, for example, someone has had treatment for Ewing sarcoma or osteosarcoma, they would be receiving very high doses of radiotherapy to the tune of 50 to 60 grays, and that can eventually lead to secondary aplastic, acquired aplastic anemia, then chemotherapy related aplastic anemia, which is often reversible. Then there are certain drugs, like I said, cotrimoxazole. There are certain anti-epileptic drugs. There are certain drugs used for decreasing raised ICP, like acetazolamide. All these can result in idiosyncratic reactions and aplastic anemia. History of herbal intake, so drug-related aplastic anemia. Then when you talk of infections, I told you hepatitis viruses are an important group of infections. So in that case, you will find a history of jaundice around 2 to 3 months prior to the current presentation as aplastic anemia, and it is often seronegative hepatitis. Then history of recurrent infections or past blood transfusions, needle prick injury, parental history of recurrent infections, think of HIV. History of fever, skin rash, the typical varicella rash, or pharyngitis, which is often found in EBV, can suggest CMV, EBV, and varicella associated aplastic anemia. Then you have history suggestive of autoimmune illnesses like rashes. So you can have mala rash, you can have photosensitivity, you may have joint pains, you may have joint swellings. There could be polyserositis in the form of pleural effusion, ascites, or there could be multisystemic involvement as seen in SLE. So SLE is a very important cause of aplastic anemia. In all cases with pancytopenia, you should run an anti-nuclear antibody test. Then there is an entity called PNH. Now, what exactly is PNH? It is paroxysmal nocturnal hemoglobinuria. So what happens is, in this, on the surface of RBCs and platelets and monocytes, usually there are these complement factors. There are certain antigens known as CD55 and CD59. So these prevent the complement activation of these cells. In PNH, the CD55 and CD59 are deficient. Now, what results, because of this, what happens is that complement starts acting on the RBCs, complement starts acting on the platelets. When the complement system starts acting on the RBCs, it results in killing of these lysis of these RBCs within the blood vessel. So intravascular hemolysis occurs. So there is history of passage of cola-colored urine. Then obviously because of hemolysis, there will be mild jaundice and there will be anemia. But what is important in PNH is there is associated thrombosis. This is because even the platelets lack the CD55 and CD59. So the complement mediated activation of these platelets occurs, and these platelets ultimately coagulate and lead to the development of thrombosis. Then there are certain immunodeficiency disorders like common variable immunodeficiency, which result in recurrent sinopulmonary infections. So child may present with recurrent history of sinusitis, ear discharge, recurrent pneumonias, recurrent pharyngitis, and when this is recurrent, deep-seated, requiring IV medications, not getting fine in the due course of antibiotics, you should think of an immunodeficiency, and when associated with pancytopenia, CVID, common variable immunodeficiency should be on your mind. Now, what is this? This is a typical scenario that you find. So what do you see in this particular picture? This is hyperpigmentation of the knuckles, typically seen in vitamin B12 deficiency. So how would you get such a child? Normally a kid around 9 months, 10 months of age, belonging to a poor socioeconomic status. Either the mother is thinly built or has been deficient in diet, has been anemic through pregnancy. There is history of vegetarian diet because B12 is not present in vegetarian food. Then there is history of associated inadequate complementary feeding. They will not start complementary feeding at 6 months. When they do start, they'll use cow's milk and they will dilute it. History of goat milk intake. So goat milk typically lacks folate completely. And if the mother is keeping the child predominantly on milk feeds, even up to the infantile age group, giving goat milk, obviously the child will become folate deficient. So all these are clues to etiology of vitamin B12 and folate deficiency, which can lead to pancytopenia. Then clinically, you may find skin darkening overall because B12 ultimately results in decreased, B12 deficiency results in decreased stores of glutathione, which results in activation of the enzyme that is responsible for producing melanosomes, that is tyrosinase. So because of increased production of melanosomes, overall darkening of the skin occurs and it is well perceived over the knuckle. So knuckle hyperpigmentation. The child may develop tremors and there might be a history of developmental regression and development of ITS in such cases. So B12 and folate deficiency, although it does not commonly result in pancytopenia, but simply because of the volume of patients in our country which have B12 and folate deficiency, it may lead to a couple of cases of aplastic anemia. So we should be ruling this out, especially because this is very, very treatable. But when you talk of other causes of acquired aplastic anemia, you will need to give immunosuppressive therapy or matched sibling donor hematopoietic stem cell transplant. So what are the clues to etiology of inherited bone marrow failure syndromes? One, early age of onset. Although I did say previously that 25% cases may still be presenting in adulthood. Then presence of certain dysmorphic features. For example, microcephaly or microphthalmia, dysplastic ears, abnormalities of the upper limb especially, very, very important. Hypoplastic thumbs, absent thumbs, bifid thumbs, absent radius, other upper limb abnormalities, lower limb abnormalities or skeletal defects, hearing abnormalities, delayed development. So delayed development, poor growth or short stature. These can tell you inherited bone marrow failure syndromes. Then in the child itself, then you will get a family history. You may get a family history of IBMFS. For example, Diamond-Blackfan anemia, it is autosomal dominant inheritance. So you may find a family history. Or dyskeratosis congenita is X-linked recessive in almost 35 to 50% of the cases. So you may get an X-linked pattern of inheritance where only males are affected, right? Fanconi's anemia is usually autosomal recessive. So you may find cases when there is history of consanguinity. So history of consanguinity is important. Most IBMFS are actually autosomal recessive. There is history of unexplained abortions or fetal deaths in the mother of the affected child. And there is family history of cancer. So you have history of hair and neck cancers, cervical cancers, which are occurring in family members at a much earlier age group than is expected in the general population. Then, and the index child is presenting with pancytopenia, think of inherited bone marrow failure syndromes. I hope you guys are with me, not gone off to sleep. So there are certain examination clues, a few pictures you have. So look at these clinical features. I've already given the diagnosis. This is Fanconi's anemia. So this particular child has short stature. So nearly 10% of cases of Fanconi's anemia has short stature. There could be failure to thrive. There is microcephaly and growth development in this kid. Growth development can occur in almost 10-15%. Then skin changes in the form of cafe-au-lait spots, skin changes in the form of generalized hyperpigmentation, skin changes in the form of hypopigmentation or vitiligo. They are present in almost 50% cases of Fanconies. And these findings, you won't get in a child like ऐसे ही देखते नहीं पता लगेगा. You have to examine the child properly, unclothe him, and look for these features, and you'll find them. Okay, so you have to look. 50% of the cases will have skin changes. Then upper limb anomaly. See, this is very in your eye. The child has hypoplastic thumb. The child has absent thumb. There could be bifid thumbs. There could be other radial anomalies. There could be other skeletal anomalies. So you should get a skeletal survey. They are present in almost, again, 30 to 40% cases will have skeletal anomalies or even more. So you have to not just stop at looking at the thumb, you have to examine the child as a whole. Then you have other examination clues. For example, this child, this has microphthalmia, there is strabismus, this child has ptosis, then they have aplastic ears, and they have bird-like faces. See the pointed nose and thin upper lips and this elongated philtrum, this plastic ears. It is said that these Fanconi anemia kids actually look more like each other than their normal siblings. So they have that typical phenotype. Now, what is this? Look at the nails of this person. This is an example of dyskeratosis congenita. So nail dystrophy. Then you have reticulate hyperpigmentation. So this reticulate hyperpigmentation. So especially in the face and the upper chest, but in this particular case, we also found it in the lower limbs. And then there is oral leukoplakia. So all these features are characteristics of dyskeratosis congenita. These features will be present along with the presence of pancytopenia. So if you look at another example, Schwartzman-Diamond syndrome, there can be exocrine pancreatic insufficiency. And when you do a skeletal survey, there is metaphyseal dysostosis or dysplasia. So you look at the end of the long bones where there is fraying present. All right, so this is fraying, and diaphysis will also be sclerosed. So these children will have associated short stature. So pancreatic exocrine insufficiency, which will present in the form of steatoria. So stools which are very fatty and which will float on the pot and will be difficult to flush away, which is suggestive of fat malabsorption, short stature, pancytopenia, and metaphyseal dysostosis on an X-ray. You should think of Schwartzman-Diamond syndrome. So now, what are the investigations? We've seen the clinical clues that we have to pick up an aplastic anemia and the etiologies of aplastic anemia. Now, what are the investigations that we should be doing? So the foremost investigation is a complete blood count with a reticulocyte count. Do not forget this reticulocyte count, because we saw even in the classification, you need that retic count with a peripheral smear. So now what will you find? There can be decreased HB, TLC, and platelets. Retic count will obviously be decreased. And there will be something called relative lymphocytosis, which I'll explain you in the subsequent slide. So pancytopenia, reticulocytopenia with relative lymphocytosis. The peripheral smear will show normocytic to macrocytic anemia. The RBCs may be slightly larger in size, but the platelet morphology and the TLCs, leukocyte morphology, is going to be normal. So, so these two are going to be completely normal. Then you have hemoglobin F, which may be slightly raised because these children have stress erythropoiesis. So a lot of fetal stress erythropoiesis occurs secondary to such severe anemias, and therefore hemoglobin F may be slightly raised. However, this hemoglobin F, if raised, can support the diagnosis of aplastic anemia. If not raised, it does not exclude aplastic anemia, and it does not have any prognostic significance. In all cases, you should be doing a baseline kidney function test. Why? Because when you want to give treatment, you will be using cyclosporine A and many other treatment regimens. Even in bone marrow transplant, drugs will be used which can lead to kidney damage. So you need to have a documented baseline normal kidney function test. Also, there are certain bone marrow failure syndromes in which the kidney function may be affected. For example, Fanconi's anemia. Then you have the liver function test. Again, baseline liver function test, because you're going to be using drugs in the treatment which can lead to liver damage. There could be hepatitis which may be associated and cause of the acquired aplastic anemia. And thirdly, there are certain inherited bone marrow failure syndromes like dyskeratosis congenita, which may lead to liver fibrosis. So you need to have a baseline LFT2. Now, this is the CBC I wanted to show you of a child with aplastic anemia. First, look at the underlying parameters. So the hemoglobin is reduced, the WBC count is reduced, usually 4,500 to 11,000. This is 2,400 per cubic millimeter. Platelet count is 37,000 per cubic millimeter. So all of them are reduced. Now, when you look at the percentages of lymphocytes, granulocytes, and the mixed cells, the lymphocytes are almost 60%. The granulocytes are 30%, and rest are the mixed cells. But when you look at the absolute number of lymphocytes, they are reduced. Because the TSE is reduced, the lymphocyte absolute count is also reduced, the granulocyte absolute count is also reduced. So this thing that actually the absolute lymphocyte count is decreased. But when you look at the percentages, the percentage of lymphocytes is much more than the neutrophils, is known as relative lymphocytosis. This is often present in children with aplastic anemia. Now, what is the investigation that you do to confirm the diagnosis of aplastic anemia? It is a bone marrow aspirate and biopsy. Biopsy is the round one. You have to do a biopsy. Now look at the picture on the left. This is a normal bone marrow. You look at all the intertrabecular spaces, they are full of cells, hematopoietic cells, and these white spaces are the fat globules. Now look at this aplastic marrow. Almost all of the marrow has been replaced by these white fat spaces, and these are the cells. Hematopoietic cells are actually limited to very small spaces. So this is a typical aplastic marrow. So in microscopy, you will find marked reduction in the cellularity of all three lines with prominent fat spaces. So now I'll skip the slide. So now what all can you send in a bone marrow aspirate? A bone marrow aspirate will give you an early diagnosis. However, it needs to be confirmed in a bone marrow biopsy. I'll tell you the reasons later. Also, on this bone marrow aspirate, you can conduct certain genetic investigations like karyotyping in fish and molecular studies. These can give you information about three things. One, the myelodysplastic syndromes. Second, the inherited bone marrow failure syndromes. For example, for Fanconi's anemia, dyskeratosis congenita, and many other inherited bone marrow failure syndromes, you can take a bone marrow sample and send it for fish karyotyping, for chromosomal breakage analysis, or for next generation sequencing. This will give you a diagnosis of which inherited bone marrow failure syndrome is there if you suspect one. Secondly, it can help in ruling out myelodysplastic syndrome, because if myelodysplastic syndrome is present, which you will also confirm with a biopsy, and with specific chromosomal abnormalities, then the treatment lines would probably change, because then you would classify this child as a hypoplastic MDS. But a biopsy, of course, is essential. Now, why is a bone marrow biopsy essential in all cases of aplastic anemia? One, because if any of you have done a bone marrow, you'll realize काफी बार pathologist क्या report देता है? Hypocellular marrow, query diluted marrow, right? So how do you know in a bone marrow aspirate whether it is true reduction in cellularity or it is a diluted marrow? That is why a biopsy is essential, because in biopsy there is no concept of a dilution. They will examine the entire biopsy. Then second is, sometimes the bone marrow cellularity is patchy. In areas it may be normal cellularity, in areas may be hypocellular, but you have to have an assessment of an entire cellularity pattern, in which situation bone marrow biopsy will give you the answer. So the risk of over and under diagnosis with bone marrow aspirate alone will be overcome with a biopsy. Third is, you need to study the morphology of the residual hematopoietic stem cells. It might be a leukemia which is associated with aplastic anemia, but you have to first check examine the remainder of the hematopoietic stem cells. What is the exact cellularity and the percentage of blasts in them? Then next is to rule out a malignant infiltrate, and in cases of dry tap of a bone marrow aspirate, biopsy is the only answer to confirm the diagnosis of aplastic anemia. Now, what are some practical tips? As residents, we often think, "Arey, iska to thrombocytopenia itna hai. How can we actually get a bone marrow done? You know, so wo to bleed kar jayega." But so and often in aplastic anemias, आपका platelet count is very low. So should I be doing a bone marrow in such severe thrombocytopenia? So you should know thrombocytopenia is not a contraindication for bone marrow aspiration or biopsy. Just applying adequate pressure at the aspirate biopsy site post the procedure is enough to prevent a bone marrow bleeding from the local site. Secondly, routine platelet transfusion before a bone marrow aspirate and biopsy is not recommended. So platelet transfusion should be given only if indicated by other criteria, which I'll explain to you later, but it is not to be routinely given before a bone marrow aspirate or biopsy in cases of aplastic anemia. And what is an adequate biopsy? At least 2 centimeters length you should be taking. You should not be sending cartilage for examination, because 2 centimeter length भेजेंगे तो उसके अंदर adequate amount of spaces examine हो पाएंगी. And secondly, you have to take it perpendicularly. If you take it tangentially, you reach the subcortical space, and subcortical space means even normal people will have hypocellular marrow. So take the biopsy perpendicularly. So now what are the next? So we have done a CBC, we have done a bone marrow examination to confirm the diagnosis of aplastic anemia. Now the next investigations are, what is the etiology? So serum folate and B12 levels, I cannot emphasize enough. Again, I'm telling you, karna hi hai. And what is important is, ऐसा नहीं होना चाहिए aplastic anemia. We think B12 folate deficiency है, चलो आज ट्रीटमेंट स्टार्ट कर देते हैं, आज तो सैटरडे, मंडे को सैंपल भेजेंगे. आपका आएगा ही नहीं रिपोर्ट. B12 and folate levels are very sensitive to supplementation with folate and oral with supplementation of folate and B12. So the samples have to be sent before you start the treatment. Then the second thing is viral serologies. So I told you there are important serologies like HIV, hepatitis A, B, C, CMV and EBV serology, and parvovirus B19 virus serologies you may send. All right. Autoimmune disease evaluation, ENA has to be done in all cases. If you have strong suspicion, dsDNA आपको confirmation के लिए चाहिए, you go ahead and do it. Now, how do you identify paroxysmal nocturnal hemoglobinuria causing aplastic anemia? You simply do a flow cytometry of the peripheral blood for CD55 and CD59. All good centers will have these facilities available for diagnosis of CD55 and 59. Additionally, you can check the urine for hemoglobinuria, because there is going to be intravascular hemolysis, so you will get a urine for hemoglobinuria, so you can send it for examination. And immunodeficiency evaluation, CVID will have hypogammaglobulinemia, so you can send a immunoglobulin profile. So these are causes for acquired aplastic anemia. Now, what do you do for inherited bone marrow failure syndromes? Specifically, Fanconi's anemia, which is the commonest inherited bone marrow failure syndrome or inherited aplastic anemia. You do a chromosomal breakage analysis. Now, before I explain you what is a chromosomal breakage analysis, why is it important to differentiate Fanconi's from acquired aplastic? Sabse pehle, Fanconi's, so there are 2 treatment modalities for aplastic anemia. One is immunosuppressive therapy, which is with anti-thymocyte globulin and cyclosporine. And the other is bone marrow transplant. आप acquired aplastic anemia में जहां bone marrow transplant नहीं कर सकते, immunosuppressive therapy will work. But if you do the same thing with a Fanconi's patient, he will worsen. It will not improve the counts, but it may harm the child. Secondly, if Fanconi's anemia patients are going ahead with a bone marrow transplant, then the conditioning regimens of chemotherapy which are given before the transplant are different from those in normal children with acquired aplastic anemia. Okay, so it is important. Third is, when you have a child of Fanconi's anemia, you have to monitor them lifelong for the development of cancers, because they are very predisposed to development of blood as well as head and neck cancer. So these are all. And why do you have to do this test then? हम उसके morphology से देख लेते हैं, characteristic physical anomalies होंगी बच्चे में. But what is important for you to know is, as I told you before, almost 30-40% cases of Fanconi's anemia will not have that characteristic physical anomalies. So the only way you can differentiate it from an acquired aplastic anemia is by doing this chromosomal breakage analysis. So what happens in this chromosomal breakage analysis? You send a peripheral blood or bone marrow aspirate or a skin biopsy. Skin biopsy का एक ही problem है. Skin biopsy बहुत centers में available नहीं होता. It is not universally available. So peripheral blood is the easiest sample to send. So most often we send a peripheral blood sample. Now what happens is that they will now add clastogens to the peripheral blood of the patient. Clastogens क्या होते हैं? These are examples in mitomycin C and dipoxybutane. These lead to induction of chromosomal breakage. These are DNA cross-linking agents. So in normal people, your sensitivity to this clastogens is not high because they have normal DNA repair mechanisms. But in Fanconi anemia cells, the DNA repair mechanisms are abnormal. So once these cells are exposed to mitomycin C or dipoxybutane, it results in breakage of chromosomes. I'll explain to you in these pictures. For example, this is a normal chromosome. See, there are two chromatids very close to each other. This is the centromere. This is one chromatid, other chromatid, other chromatid. Now look at this arrow. In this particular chromosome, this area of the chromosome is missing. It is broken. In this particular arrow, this area of chromosome is broken. So and so and forth in many other areas in this. So there is chromosomal breakage which occurs on exposure to clastogens, and this helps in diagnosis of Fanconi's anemia. The problem is if the child has been transfused, then you will have blood cells of the donor. So in that situation, wait for 2 weeks before the test. And sometimes if skin biopsy is available, in that situation, you can send a skin biopsy for skin fibroblast evaluation for this test. Investigations for other IBMFS, next generation sequence is the best test. If available and if affording, you should go ahead. But if the patients can't, then we are kind of stuck as in many of our situations. Now, what is the treatment? The treatment of aplastic anemia, that is the gone bone marrow, is divided into two parts. In all cases of acquired and inherited bone marrow failures, that is inherited as well as acquired, you will need a supportive care. Supportive care includes blood transfusions, infection control, hematopoietic growth factors, and iron chelation, which I'll be explaining in subsequent slides. And then there is definitive treatment, which is a curative treatment, matlab jad se nikal diya. So that can be of two types. So hematopoietic stem cell transplant and immunosuppressive therapy. Now what you should remember is, in inherited aplastic anemia, the answer is only hematopoietic stem cell transplant, especially in Fanconi's anemia. Immunosuppressive therapy will not work. Whereas in acquired aplastic anemia, all the treatment of choice still says hematopoietic stem cell transplant, but if it is not available, immunosuppressive therapy is known to give good results. तो ये चीज बहुत याद रखनी है कि HSCT भी है, immunosuppressive therapy है, लेकिन immunosuppressive therapy primarily will work in acquired aplastic anemias, which are almost 70% of the cases of aplastic anemias. Now, first I'll elucidate upon this supportive treatment. Prevent alloimmunization, बहुत important है. So transfusion नहीं, ये नहीं है aplastic anemia, बच्चा आया, चलो जी transfuse कर दो. You have to transfuse judiciously because otherwise they will develop alloimmunization. And the moment you have to do a bone marrow transplant, this alloimmunization is going to be your biggest enemy. So you have to prevent alloimmunization. So how to prevent? Transfuse judiciously. If HB is less than 6 or if platelet count is less than 10,000 per cubic millimeter. Now, second thing is, in these situations, tell the blood bank that we need to give blood which is both major and minor blood group matched. Use leukocyte depleted और irradiated blood products. इनमें क्या होता है, leukocytes हट जाते हैं blood products से. So the risk of aluminization, that is developing antibodies against the WBCs of the transfused cell, decreases. तो वो हमें क्यों करना है? Because अगर subsequent हम बच्चे को bone marrow transplant देना चाहते हैं, the success of it will depend on how carefully you have taken care of aluminization. Use single donor origin blood products. And what is very important, normal बच्चों में हम क्या बोलते हैं, चलो जी मम्मी पापा आप दे के आओ, खून दे के आओ. कैंसर के बच्चों में यही करते हैं ना, you go and give blood. But in situations में you have to avoid transfusions from blood relatives, because ultimately you are going to look for a matched, HLA matched sibling donor which or a family donor. और अगर वही डोनर हो गए और उनसे पहले आपने ब्लड ट्रांसफ्यूजन दे दिए तो आपका एल्यूमिनाइजेशन बिल्कुल ट्रांसप्लांट डोनर के ही एंटीजन से हो जाएगा. ठीक है. So you have to avoid transfusions from blood relatives in aplastic anemias to prevent sensitization to transplant antigens. Very, very important part of management. Okay. Now supportive treatment will also include other things. अब एक question आता है, what about these hematopoietic growth factors? Like we have a tendency to routinely give GCSF and EPO. But actually, though guidelines, especially the IAP guideline, which has been there in Indian Pediatrics, published in 2022 by a group of very renowned authors who are practicing hematologists all over India, they say there is no role of routine use of GCSF or EPO in these cases. GCSF may be given if a child of aplastic anemia develops life-threatening febrile neutropenia. Now, the role of L-thrombobag. L-thrombobag is something which is going to promote the platelet production. These in adults, it is known to have a role. In children, there is lack of sufficient RCTs. So the guidelines say that you may give L-thrombobag to these patients. Now, because of so many blood transfusions, the next problem is of iron chelation. Iron overload is because you're recurrently giving blood transfusions. So what about the chelators? Just like in thalassemias, when the serum ferritin levels become more than 1000 nanograms per ml, add subcutaneous desferrioxamine or oral deferoxarox, because these kids are also prone to develop side effects of iron overload. So you should be monitoring the levels of serum ferritin. Now, what are the things that need to be avoided? Avoid drugs like aspirin. It is known to cause aplastic anemia, and of course, you know that it is going to inhibit the platelet function. So you have to avoid aspirins. Avoid intramuscular injections because predisposes to development of local site bleeds and hematomas. Use antifibrinolytic agents like tranexamic acid and epsilon aminocaproic acid if needed. Although hematuria is a contraindication because it can lead to development of intra-bladder clots, which can then lead to need for surgical removal. Okay. But otherwise, fibrinolytic agents are known to be beneficial in these cases. Someone who is having in the menstrual age group, hormonal therapy can be given to suppress the menses, like as a contraceptive measure itself. Now, next is how do you control infection? So, aggressive management of febrile neutropenia. So, when a child of aplastic anemia develops fever and he has neutropenia, there is no, you can't treat that child like other pneumonias. Fatapat se IV cannula, first shot of IV antibiotics, which should include an anti-pseudomonial coverage, like ceftazidime or ciprofloxacin or meropenem. You have to go Magnex, vancomycin, all these. So coverage of pseudomonas is important in such situations. It should be managed aggressively. Upgradation of antibiotics has to occur carefully, and then you go on to antifungals by 96 hours if non-response to fever is there. Of course, you're going to do all your workups to find out the focus of infection. Patients on immunosuppressive therapy to receive septron prophylaxis. Now, I found that Lanzowski's, which is a textbook of hematology oncology, does recommend giving septron prophylaxis, although the IAP guidelines say that on immunosuppressive therapy with cyclosporine and anti-thymocyte globulin, you do not need a septron prophylaxis. So I think we can follow what the center prefers in terms of using the ceftriaxone prophylaxis. Antifungal prophylaxis in very severe aplastic anemia is recommended. Actually, voriconazole is a drug of choice because aspergillus is often the causative organism, and fluconazole prophylaxis will not work in such cases. So where available, voriconazole prophylaxis should be given in children with very severe aplastic anemia, where the ANC is less than 200 per cubic millimeter. So now, supportive treatment to all children of aplastic anemia, definitive treatment, that is immunosuppressive therapy or bone marrow transplant, whom to treat. So acquired severe or very severe aplastic anemia, that means that in cases of moderate or mild aplastic anemias, you may just follow up. However, if these mild to moderate aplastic anemias, that is non-severe aplastic anemias, develop significant transfusion dependence, in that situation also, you should think of a definitive treatment options. Now, what are the definitive treatment options? The best is allogenic hematopoietic stem cell transplant with a matched sibling donor. It is the treatment of choice for both acquired as well as inherited aplastic anemia. In acquired aplastic anemias, if matched sibling donor is not available or there are issues in arranging for a bone marrow transplant, then immunosuppressive therapy is used. Immunosuppressive therapy consists of horse antithymocyte globulin, which inhibits the T-cell mediated autoimmunity. You use cyclosporine. Cyclosporine is given orally and it is continued for at least an year before tapering off when a child responds to this therapy. Methylprednisolone is given in the initial phase of IST, that is antithymocyte globulin, to prevent serum sickness, and growth factors as required. So this is the prime treatment. Definitive treatment for inherited bone marrow failure syndromes, it's a matched donor, sibling donor HSCT. Without HSCT, pending HSCT, androgen therapy has been used in Fanconi's anemia. So oxymethylone therapy has been used in Fanconi's anemia, which results in remission in almost 50% cases, but they are predisposed to long-term side effects of not having received a bone marrow transplants, which includes MDS, development of AML, and other blood cancers. Prednisolone has been used in Diamond-Blackfan anemia. But having said that, in inherited bone marrow failure syndromes, HSCT is the treatment of choice. Now, management of inherited aplastic anemias is more challenging than acquired due to increased risk for complications from organ dysfunction, because they have other organ dysfunction which is associated, other physical anomalies that are present. They have excessive sensitivity to chemotherapy as well as other therapy treatments. And they have to be monitored for cancer development at various sites over a period of time. So actually, inherited bone marrow failure symptoms are far more tougher to treat than acquired aplastic anemias. What is the prognosis? The long-term survival is more than 90% if the child receives HSCT or IST. Then why should we choose one over the other? The problem is the secondary things that happen. The 10-year cumulative cancer incidence, if you give immunosuppressive therapy, it is almost 20%. But if you give bone marrow transplant, it is only 3%. 10-year cumulative MDS incidence, myelodysplastic syndrome, and I'm not just talking of inherited bone marrow failures, I'm also talking of acquired aplastic anemias. आप IST देते हो 10% chance of MDS. With bone marrow transplant, only 0%. 10-year cumulative acute leukemia incidence, almost 7%, either 0.25%. 10-year cumulative solid tumor incidence is nearly the same. So this table is from Lanzowski's. So it clearly shows that if you have the availability of bone marrow transplant, short-term survival दोनों में अच्छा होगा, लेकिन long-term survival is better with HSCT if it is available, and HSCT be specifically matched sibling donor bone marrow transplant. Without definitive treatment, mortality from severe aplastic anemia approaches 70% at 2 years. So आपने ना IST दिया ना bone marrow transplant करा, severe aplastic anemia are going to succumb by 2 years of age. So I'll end this session by saying, this is a quote from Madame Curie, who is the one I showed, who actually is an excellent physicist and chemist and a Nobel laureate. You are all are aware of her. Took an active part in so many discoveries related to radioactivity, ultimately succumbed to radiotherapy-induced aplastic anemia. This is a quote by her. Nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. And this holds true not just for the patients of aplastic anemia, you need not fear, but also for us physicians who are going to be treating all these aplastic anemias. So let's join hands and learn more about these diseases. Thank you. I can take a few questions if you have.
Yeah, Dr. Puneet, the basic one question posted in the question answer is explain single donor origin blood products.
So that means that, for example, you have platelets. So a single person should be giving single donor platelets. From that person only, the entire platelet is going to be apheresed. Instead of random donor platelets. Random donor platelets किस तरीके से बनते हैं? आपका there are different donors. Blood bank में अलग-अलग donor से अलग-अलग packets of platelets लिए होते हैं. And at different points in time, child is receiving platelets from different people. Donated by different people. तो उस situation में क्या होगा? आपका exposure to antigens would be much more than when you are receiving the blood products from a single person. That is what it means. What else?
Dr. Binita, you can ask your question. You have raised your hand.
Yeah, what's the question? Tell me.
She wants to ask orally. Dr.
Yeah,
Binita,
that's
can
okay.
you hear?
Perfect. What's the question? Please ask.
Dr. Mamta.
You can ask. Dr. Benita, you can unmute yourself and ask me.
She's unmuted.
But I can't hear the question, sir.
I think she's still muted.
Yeah, she's still muted. You can type in the question if you feel like typing the question.
Dr. Ashima. Dr. Ashima, Dr. Mamta.
With a lot of people who are raising their hands. But
There is one more question.
Yeah.
To diagnose aplastic anemia, how much should be reticulocyte count and absolute reticulocyte count?
So see, to diagnose aplastic anemia, as I showed you the slide, in cases of severe aplastic anemia, you should have a reticulocyte count less than 20,000 per cubic millimeter. So it is not given in percentage, it is given rather in cubic millimeters. And your normal absolute reticulocyte count is 50,000 to 1.5 lakhs per cubic millimeter. So, and obviously it is not in isolation that you diagnose the aplastic anemia. There should be associated hypocellularity of the bone marrow less than 25% with decrease in 2 of the 3 cell lines. That is RBCs, in which situation you look at the reticulocyte count, platelet count, which should be less than 20,000 in cases of severe aplastic anemia, and a TLC absolute neutrophil count, which should be less than 1,500 per cubic millimeter.
A 10-year-old male on weekly romiplastin injection now has increased requirement of blood transfusion now every 15 days, no matched siblings. How can we proceed?
Right, 10-year female. No matched siblings. So, have you identified the underlying cause of this aplastic anemia? Is it acquired? Is it inherited? See, Dr. Sumita, in this situation, the most important thing would be for you to delineate to the best of your judgment whether it is an inherited bone marrow failure or it is an acquired bone marrow failure. To definitely rule out inherited bone marrow failure, one, you can do a chromosomal breakage analysis. If you've already received the report of it and it is negative, you should go ahead and get a next generation sequencing to rule out any other inherited bone marrow failure syndromes. And by saying this, I'm presuming that clinically and by biochemically and all, by the routine examinations, you have been unable to identify the underlying cause. If the child is, if you're able to label it as inherited bone marrow failure syndrome, then the option is only a bone marrow transplant. If you cannot go ahead with a matched sibling donor bone marrow transplant, in that situation, if it is a Fanconi's anemia, oxymetholone therapy is known to help. So you can try that. Almost 50% cases respond. In cases of Diamond-Blackfan anemia, if you're thinking on those lines, then prednisolone therapy. This keratosis congenita, various therapies have been tried. But truly, short of a bone marrow transplant, these kids are unlikely to stay in remission for long. If you're thinking of an acquired aplastic anemia, in that situation, you should go ahead with an immunosuppressive therapy. And you can just give a platelet transfusion to maintain the counts around 30,000. Start with and ensure that infections have been taken care of. And start with anti-thymocyte globulin, prednisolone, and subsequently cyclosporine therapy. So this is how you can go ahead in this particular case. Okay, so Jasmine has asked how much is the long-term survival after bone marrow transplant? If done in younger kids, bone marrow transplant of a long-term survival, especially in the Western literature, has been reported almost to the tune of 90%. Whereas with immunosuppressive therapy, a range of 65% to 90% has been reported. But that is short-term survival with this thing, immunosuppressive therapy. Long-term survival with bone marrow transplant to the tune of 90% has been reported. Anything else? I'll just check at the question list.
Role of anabolic steroids in Fanconi's anemia.
Yes, so definitely there. Because short of a bone marrow transplant, we are using oxymetholone therapy in children with Fanconi's anemia, and almost 50% respond to that, and they stay in remission for quite some time in that situation. However, the problem in using this therapy is that they will always be at increased risk of developing MDS, AMLs, and subsequent hematological malignancies.
Role of rituximab
In aplastic anemia?
Yeah.
No, I'm not aware of the role. I mean, probably more senior people will have an answer, but so much so I have gone through in the books that are standard books that are there, Lanzowski's and Nathan and Oski, and I haven't really come across the role of rituximab in a case of aplastic anemia. So that's a tough one for me to answer.
Please tell on ATG therapy in brief.
All right. So I didn't want to delve into this, but since you've asked, so anti-thymocyte globulin, what it is that we are going to retrieve some immunoglobulins after injecting certain antigens in the horse serum. And from there, horse or rabbit serum, we are going to collect and make this therapy known as anti-thymocyte globulin. How it acts is that when you inject it into the patient of an acquired aplastic anemia, it is going to inhibit the cytotoxicity of the T cells, which are ultimately resulting in autoimmune destruction of the bone marrow. Now, this ATG therapy is once a child is free of infections and the platelet has been stabilized at least maintained at least 30,000 per cubic millimeter, you use a central line to give this to prevent any local reactions. And you also need it because ATG therapy ultimately can lead to serum sickness. So you start this ATG therapy in the standard doses 2 mg per kg per day, and you infuse it via the central line very slowly, and also monitoring for the development of serum sickness. From day 1 to day 5 or 8, we give ATG therapy via central line. Along with that, we give steroids, usually methylprednisolone from day 1 to day 8, because we have to prevent serum sickness. And then alongside we start with cyclosporine A therapy. Now this in combination is known as the immunosuppressive therapy. When you give this immunosuppressive therapy, they say that short-term recoveries of up to the tune of 65 to 90% are documented in children with acquired aplastic anemia. So in our scenario, when many a times either we don't have the bone marrow transplant facility at our centers, or if we have, we do not have a matched sibling donor HSCT. In that situation, IST is to go thing in acquired aplastic anemias. Okay.
Can we give irradiated RBCs for PRBC? Is there any specific instruction for platelet transfused?
Yes, so you should give irradiated blood products, all of them. And in platelets, of course, single donor platelets are preferred over random donor platelets because that is going to decrease the risk of alloimmunization.
How long to use immunosuppressive therapy after bone marrow transplant?
I think it has to be used for around 5 to 6 months at least, and then slowly tapered off.
Well, I think questions are over. Dr. Kawaljeet, your comments and any discussion you would like to have?
Yeah, yeah, very nicely presented. Yeah, it's a difficult topic, and not most of the time we are dealing with nutritional anemias only. So she has nicely covered in detail, and she has taken pains to explain all at the resident at the MD level. So it is nicely done too. Nice content as well. One thing, few things just I wanted to add, like the role of rituximab. So basically, it is a T cell mediated immune destruction if we think it is a autoimmune aplastic anemia. But there are like isolated case reports that it has been work effective and all that stuff. But with rituximab, we have to be careful because it can increase the risk of infections, and we already have neutropenia. So anecdotal reports are there where it has been found to be effective. As such, I guess it is not a part of the guideline as a recommendation as such. That is all about it.
Thank you so much, Kamal ma'am. Thank you for explaining also, and thank you for all your appreciation. There's one more question. What is the cutoff for platelet transfusion in aplastic anemia? Usually we take a cutoff of less than 10,000 per cubic millimeter in afebrile patients, and in febrile patients we take a cutoff of 20,000 per cubic millimeter.
Thank you, Dr. Puneet, for this session. I think we had around 200 plus participants, and I believe everyone was benefited out of it. And we thank you very much for taking out your time and coming on this platform. And this was the 13th session of this series, and we have 3 more to go. And we look forward everyone to be there on 3rd of September at Chacha Nehru Bal Chikitsalaya, Gita Colony, New Delhi. There will be a full day workshop followed by a convocation there from 9 a.m. to 3 p.m. And we invite every participant who has registered for this event over there on 3rd of September, that is Sunday. See you next Sunday morning, 9 a.m. with another session. Thank you, Dr. Puneet.
Thank you so much, Vipul sir. Thank you for having